path for getting air into the lung. An unresponsive person can lose muscle tone. If flat on his or her back, the base of the tongue can relax and obstruct the airway. This is the most common cause of a blocked airway. The tongue is attached to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat and opens the airway. You can open a person's airway by using the head tilt chin lift technique. Place one hand on the forehead. Place the fingertips of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. Before using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it upward and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. A bag mask device allows rescuers to provide rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by two. From above the head, place the mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bag slowly enough to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, a person will not survive regardless of injury. When the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered. Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull the pads have pictures on them to show proper movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs,
Connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care. The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers. Slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
Heather? Heather? Heather, breathe! Heather! Heather, breathe, please!
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, can you hear me? Ma'am, can you hear me?
A person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch, P37. Can you advise EMS this is a possible overdose? She's not breathing but has a carotid pulse. I'm gonna start rescue breathing.
Copy P37. Possible overdose. Rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm gonna keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak to adequately move blood forward. Signs of poor blood perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
Let me take over for you.
How long has he been down?
Just a few minutes.
Sir, are you all right? One, two, three. Five, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
Stay clear of patient. Analyzing. Shock advised.
Everybody clear?
Stay clear of patient.
CPR can or even before anything else, pause and assess the scene for hazards. If it is safe, quickly. If unresponsive, quickly normal breaths. Have someone activate your emergency response protocol and quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear
make
of
sure you are not touching the person before delivering the
Deliver
shock.
shock now. Shock delivered.
Immediately starting with compression. Voice instructions and additional analysis by the AED will guide you through further care. Don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Hold up, stop CPR. He's responding.
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. Continue to follow the AED's instructions. Compression-only CPR is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. breaths. The compressor pauses to allow rescue breaths to be given. Give breaths as quickly as possible to minimize the interruption. High-quality compressions are tiring. If an AED is not attached, switch every 2 minutes at the end of a CPR cycle. Clearly communicate the details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relieve the compressor while rescue breaths are being given to shorten the interruption. With 2 providers, use a 15:2 ratio of compressions and breaths for a child or infant. When 2 or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Yes. Our lifeguards are responding now.
Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
1, 2, 3, 4, 5. Yes, I hear the sirens. Oh, they're here.
Stop CPR. Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1,
Begin
2, 3,
CPR.
4, 5, 6, 7, 8, 9.
The team leader takes a general perspective to supervise and improve overall team performance.
What's the story?
He was exercising in the water and then he collapsed.
How long since you started?
Effective team communication is essential. Speak calmly and in simple terms.
2 to 3 minutes.
Was it witness?
Yes.
This person is also the main point of internal and external communication. If you are asked to do something, repeat it back to confirm and reinforce the instructions. Other roles may be filled as necessary. A second ventilator to help with the use of bag mask, or a scribe or reporter to document patient information, treatments, and intervention times. In the transition to more advanced care, additional roles for actions such as administering medications may be added. When an AED is attached, plan to relieve the compressor during the time an AED analyzes the heart. This typically occurs every 2 minutes.
Are you guys clear?
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, a facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is no longer necessary to pause compressions to give breaths. Provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute. Choking can occur when a solid object, such as a piece of food or a small object, enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. I need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange, the lack of sound, and the inability to speak or cough forcefully.
Chrissy? Are you choking? I can help, okay? Stand up. Try and get a breath. Try and get a breath. Let's do that.
A person without any air exchange requires your help to survive. If you suspect someone is choking, ask, "Are you choking?" If the person nods yes or is unable to speak, cough, or cry, act quickly. Stand behind the person. Kneel behind someone who is sitting. Reach around and locate the person's navel with your finger. Make a fist with your other hand and place the thumb side against the abdomen just above your finger and below the ribs. Grasp your fist with the other hand. Give a quick inward and upward thrust. Each thrust needs to be given with the intent of expelling the object. Repeat thrusts until the person can breathe normally. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate the emergency response protocol for the setting. Begin CPR starting with compressions. Look in the mouth for an object after each set of 30 compressions and before giving rescue breaths. Remove any object if seen. Continue care until the person starts to move or another BLS provider takes over. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try not to put pressure on the ribs. If you are choking and alone, try pressing your abdomen quickly against a rigid surface, such as falling onto the back of a chair. If one is not available, attempt abdominal thrusts on yourself. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. For a choking child, the approach is nearly the same for adults. It might be easier to kneel behind a choking child to deliver thrusts. Use less force on your thrusts. Because infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Lay the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. If not already done, have someone activate your emergency response protocol and begin CPR. Look in the mouth for an object after each set of compressions and prior to giving rescue breaths. Remove any object if seen. Abdominal and chest thrusts can cause internal injury. Anyone who has had these maneuvers used on them should be evaluated further to ensure there are no injuries. Opioid overdose can severely reduce or eliminate a person's effort to breathe. Naloxone is a drug that can quickly reverse this effect. The initiation of CPR, activation of your emergency response protocol, and use of an AED should not be delayed to administer naloxone for a suspected opioid overdose. One method of administering naloxone is through a nostril using a pre-filled syringe with an attached mucosal atomizing device. If you have reason to suspect the person's condition is related to an opioid overdose, administer naloxone without interrupting ongoing care. Take both parts of the pre-filled syringe out of the packaging. Remove both caps from the larger hollow tube and the cap from the smaller capsule with the medication. Gently slide the medication capsule into the hollow tube and fully screw the capsule in clockwise. Gripping the plastic wings of the atomizer, fully screw the tip of the hollow tube clockwise onto the atomizer. Insert the white cone tip of the atomizer snugly into a nostril. Give a short, vigorous push on the end of the medication capsule and spray about half of the medication into the nose. Repeat the technique on the other nostril to give the remaining medication. Continue CPR and the use of an AED if one is available. If normal breathing does not return, administer a second dose of naloxone using another pre-filled syringe. Calm and reassure someone who responds. Opioid withdrawal symptoms can occur and be unpleasant. The effect of naloxone is temporary, and breathing may become depressed again. Anyone given naloxone should have continued medical evaluation.
Access to the fountain of youth. Pangalawa is gender. So pag lalaki ka, mas prone ka sa MI. Siyempre, ang lalaki, ano siya ang hormone niya is a warring hormone, no? It's an active hormone. So there's an age bracket also sa female na ang mataas ang count na nagkakaroon ng CVA or cerebrovascular accident. Sa female, nakalimutan ko yung bracket ng age group kaysa sa men. Pero most counts na MI sa lalaki. Tapos third, gender, age, tapos gender, age, and grabe ang memory ko. Tatlo yun. Non-modifiable, you cannot modify. Baka may maalala kayo. Grabe, naghang yung utak ko. There's nothing you can do with that. Lalo ngayon, tumataas na yung count, no? Tumatabi sa diabetes, which is contributory to the heart ailment or the cardiovascular ailment. Doon sa modifiable, medyo marami-rami na. Uncontrolled hypertension, pinapabayaan na hypertension, hypercholesterolemia. Kailangan kinokorek natin yun eh. Pwede pa tayo mag statin versus mag-fibrates. Tapos hyperglycemia, siyempre lalapot yung intravascular space natin, kakabog, hirap si puso mag-ano. So pababain natin, control natin ang blood sugar. Ano pa? Smoking, naku, Diyos mio. Grabing guilty dito sa Pilipinas. Even amongst doctors, no, nigarilyo. As i-justify pa sa harap ko na here and that, no? Grabe. We know that it's not really healthy. No? I could not find the logic. I'm really sorry, I could not find the logic there. But gano'n. And ano pa, sa mga modifiable. Obesity, ano pa, sedentary lifestyle, tapos stress, no? Yung stress, wala akong magawa. Pag ayaw nyo ma-stress, huwag kayong tumingin sa salamin. Doon sa modifiable, this is where we are trying to target para mahabol natin. Sa mga non-modifiable, yung age, yung gender, yung may isa pa eh. Grabe, come on. Age, gender. Grabe naghang. Anyway, pag naalala ko mamaya sabihin ko. And it accounts to the main killer in the whole world. Sabi ng WHO, global scare. Maigi pa nga ang maigi pa ang COVID eh. Bago ka maging abo, simula sa ubo na maging abo, nakaporma ka pa, pwede ka pa mag-TikTok. Dito pag nag-massive MI ka, wala nang closure, di ka na magising sa umaga. Diretso ka or massive stroke na. So it's really ugly. And we are not actually reversing it despite the advances that we have, no, in medicine. And we have a problem with the behavioral aspect. That's why part of the program of ACLS is to let them understand some preventive measures natin, paintindi sa atin, kaya doon sa chain of survival, yun yung ine-emphasize yung prevention. No? So, what are our objectives? First is we have to describe what ACLS is. Balik tayo sa chain of survival, balik-balik, no? And then pathological ECG. So, I'm not gonna teach the whole part of ECG. Yung ECG lang in a blitzkrieg manner. Yung maka-identify lang kayo para matreat natin. So, kung kayo, doktor kayo, IM or cardio, nakikinig sa akin ngayon, ang ituturo ko lang, sisiyo lang to sa inyo kasi pathological lang. Something na, ano lang sa battery ng ACLS. Don't expect me to discuss brugada or perhaps early takeoff in Wall Parkinson White. Nothing of those. Okay. Then we go into the pharmacology, ACLS pharma. Then stations for advanced airway, cardioversion, transcutaneous pacing. And then paano natin i-perform yung mega code. So itong picture na to, ito yung galing this guy, this is from California. And she was the one instructing us on, ginawa nila akong instructor for AHA. No? Itong iba, provider course sila for ACLS. Parang nagturo siya on two scenario. Training me to be instructor, tatlo kami, and then training yung na mag-join itong iba to be ACLS grade. Ito naman, dati sa Coast Guard when I was teaching, Coast Guard, sa isang EMT school for advanced life support sa wilderness. ACLS is an intervention where you employ algorithms to guide you on how to address to an arresting heart, stroke, ACS, and life-threatening emergencies, cardiovascular emergencies. So it's all about algorithm. Mas madali na nga algorithm nyo ngayon kaysa sa panahon ko. Grabe yung algorithm namin. Ngayon mas pinadali nila. It is uh, an intervention where you will do issues light access, and you push drugs, and you employ advanced airway maneuver, and it must be performed by people who are trained. Like after this ACLS, once napasa nyo, then you are that. No? Kasama kayo dun sa code blue team na gagawin ng hospital ninyo, and then kayo yung front line when there is a code blue scenario inside your hospital. So depende kung anong tao nyo. Kasi meron silang tinatawag na spinal team, may crash team for stroke, merong code blue team, merong code red pag fire scenario yata yung hospital. So sino maka-avail nito? EMT na advanced na, nurses of course, doctors, yung paramedics of course, no? And even combat medics. Combat medic advanced na yan din sila. Flight medic of course. So ang scope natin, balik tayo sa 2020 protocol with 2022 interim guidelines for ACLS, ECG reading, pharma, advanced airway, IVIO. So hindi ako magtuturo ng IV. Common na yun eh. Ginagawa nila yun. Ang IO na lang ipapakita ko sa inyo kasi nagawa ko siya live at meron akong training kit. Tapos defibrillation versus cardioversion. Tapos paano gagamitin ng capnography na hindi pa uso sa Pilipinas pero since 2012 pinapauso ko hanggang ngayon 2023, more than 10 years. Wala pa ako nakita sa pre-hospital care na nag-capnometry. Then transcutaneous spacing by principle ituturo ko lang. Tapos how to do megacode, review lang sa ACS konti saka sa CVA. Hindi ko ako mag-in-depth kasi usually papasok yan sa cath lab eh. So bitaw na ako doon kasi cath lab na yan. Pag ICU, MCU, PICO, bitaw ako doon kasi ang ACLS is mainly is like a blitzkrieg lang kung anong gagawin mo intervention. Hindi siya doon sa sustained critical care. Then turuan ko kayo ng hypothermia kasi mayroong mga bagong protocol ngayon sa hypothermia, no? And the reversible causes of reversible the reversible H&Ts. So ACLS is the cornerstone of our advanced life support courses. Pag magaling ka sa ACLS, medyo nakahon mo na tong ibang advanced life support. So, ano yung 10 core ACLS cases? Yung respiratory emergency, tapos yung cardiac arrest caused by BFib, pulseless beta, PIA, yung pulseless respiratory systole. Tapos yung types of pre-arrest emergencies, yung bloody, stable tachy, unstable tachy, and acute ACS, tapos stroke, no? So yan yung ating kailangan madaanan. Again, balik ulit tayo sa chain of survival kasi ito yung backbone ng BLS sa ACLS. No way na dito ka, nag-CPR ka, lukso ka dito, lahat to, sa inyo hospital. Hindi ka pwedeng more. One of the things that I want you to know, particularly when you read man ACLS, magugulat mo, pag mention ng halimbawa CPR, compression, makikita na meron silang COR, class of reputation, saka katabi ng is LM evidence. Pag sinabi mong STAR, automatic class 1. Pag sinabing class 1 yun, yung kanyang benefit over the risk ay 3 times. So it's highly recommended. So makikita mo yung defense. Kasi ito yung resulta ng mga meta-analysis sa lahat ng gawa mong intervention, whether pharmacologically or electrical therapy or other modalities like a CPR, no? Tapos yung nilagay din yun, precordial thumb saan siya dito. So precordial thumb, nilagay nilang kaya class 2B. So hindi ko na maalala kasi hindi ko naman nilagay po libro. So ito yung pag meron kang sariling manual, meron akong sariling manual na bagong ACLS. Binigay sa akin galing US no, sa Texas. Maraming COE, COR and LOE. So ito class 1, pag 2B ka, moderate siya, yung benefit is 2 times greater ng risk katulad ng pagbigay natin. So si class 2A yata yun. Yeah, I think class 2A. Tapos si defibrillation, class 2A yun. Tapos class 2B, ito yung the likes of procainamide, yan. Tapos itong class 3, hindi na natin yan, hindi yan ano, sorry, hindi natin binibigay. And then, merong class 3 na, hindi ko mabasa. Basta itong pababa na to, diba ito, nandito si sodium bicarb, no? Kasi dati, sa Pilipinas, mahilig pag may sodium bicarb, sodium bicarb. So, hindi natin yan binibigay sa usual arrest, no? Dito rin sa level of evidence, pag sinabing vasopressin, so si vasopressin, wala na yan, out na yan. Tapos sa level of evidence niya, doon sa randomized, nakita nila na hindi siya beneficial. Hindi niya kayang tapatan ang kayang gawin ng epinephrine. So in-out na siya. So mga ganon. So whenever you see modalities or even treatment chemically, like a pharmacologically, in the pharma of ACLS, madadaanan mo itong COR and LOE. Abbreviations, I will not discuss, basahin nyo na lang. So ito yung adult BLS natin, yung luma, hindi ko nalagay yung bago. Okay? And then, para mag-ACLS ka, ito na yung bago ngayon. This is the 2020 with 2022 interim guidelines. Medyo maliit lang. Ngayon, isinama na to. Okay? So, ang emphasis lang dito, ang makamuna don't PPE sa BLS mo. Tapos, pag-start ng CPR, kung wala kang BVM, naka-attach ka sa non-rebreather mask, and then hook to the defibrillator or AED para makita natin kung shockable versus CPR ka. Tapos sa isang ideal setup, habang nagsi-CPR ka, intubate na kaagad yun. Diyan sa asystole, kita mo. Hindi natin i-rely sa AED. Kailangan may cardiac monitor ka. Tapos sa cardiac monitor, kailangan makita mo may flatline ka on all leads. Anong ibig sabihin on leads? Halimbawa, ang default lead natin is lead 2. Kita mo sa lead 2. Makikita mo dun sa screen mo, merong dalawang Roman numeral. Tapos pindutin mo yung lead, mag-lead 3. Pag pindutin mo yun, magpo-formang square or makalagay paddle. Pag formang square, ibig sabihin paddle. Ang nagde-determine noon paddle. Pindot ko isa, babalik sa Roman numeral 1. Pindot ka, flatline, yun. Okay? Pag sira ang lead, erratic yun, artifact yun. Tandaan nyo, kailangan alam nyo yung machine niyo. Yan ang mga problema natin, hindi natin kinakabisa machine, lalo na yung bago. Pag bago sa ospital, lalo na doktor, hindi nakikialam yan sa machine eh. Pakialaman nyo ang machine. Kasi, ang laro sa operational man, the machine and the mission. You are as, I'm sorry to tell you, kahit pa sabihin, mag-rely ako clinical, fine. Kung magaling ka clinical, may machine ka, malayo ang bentahe mo kaysa sa walang machine. Parang halimbawa ako, ang laryngoscope ko, naka-video laryng. Meron pa akong mga supraglottic. Tapos ikaw, mano-mano, patatalo kita. Ibig sabihin sa advanced airway, iwan na kita. Tapos, ang IV mo, IV ka lang, wala kang ma-access. Gusto mo mag-perform ng venous countdown. Ako, meron akong IO. Nakaline ka agad ako. Ikaw mag-venous countdown ka pa lang. Epinephrine lang. Ako, meron ang ribaw, pambrady. Meron akong NOR-E, meron akong DOPA, DOBU, depende ko anong klaseng brady. Matatalo kita. Yun yung point ko. Ang medicine is reliant on lots of external factors. Magaling na doktor ka, pero kailangan meron ka maraming nagamit para mas marami ka makita na patient at mas mabilis. That's the point. ACLS is like that. Kaya dito, nakalagay dito, no? Naglagay sila ng bagong square na kung saan i-intubate mo. Intubate mo kaagad ang tao. Which is, hindi naman siya mahirap baguhin kasi kailangan sa crash cart natin, ang kailangan lang talaga, ang crash cart is readily available. Ngayon, kung ang crash cart mo sa isang maliit na clinic, nag-iisang crash cart para sa ER, itakbo mo siya doon sa ward, gano'n, no? Kasi wala kang ICU, may ER ka lang. Yun ang magiging problema natin. Lalo na pag sa probinsya ka, si crash cart itatakbo pa doon sa long hallway, no? Papunta sa kung saan ka, parang gano'n ang mangyayari. Pero kung yung crash cart mo medyo nakadistribute, mawi-wave na tong problem ko dito sa gitna, yung prioritized intubation. Ngayon, ang intubation naman sa ACLS, hindi siya mahirap kasi hindi katulad sa trauma na i-RSI ko pa, rapid sequence intubation. Dito hindi. Ang patient unconscious niya, arresting na, tubuhan mo na diretso, hindi pumapalag yan eh. Kasi palapit na yun sa kamatayan eh, no? Parang gano'n ang ano. So, totally unconscious yan. So, you can just intubate without, instituting rapid sequence intubation or induction. So, dati, ito siya, both requires intubation, tapos shockable rhythm, shock ka ngayon, dapat meron ka ng IV or IO para makabibigay ka ng epi. Tapos, kung pwede makabit mo doon sa tamper, yung mechanical compression device. Okay. So yun yung dapat na setup natin. Ngayon, dito ako sa asystole, kasi wala akong shock, kailangan mabilis ako maka-intubate kaagad. Dati kasi ang intubation, nandito banda yon, except for asystole. Yung intubation ngayon, parang siyang asystole. Kung pwedeng mauna mo. Kasi dito naka-start CPR ka, naka-fire ka na, boom, pag-fire mo, dapat after 2 minutes, intubation ka. Dito, ang hina-highlight dito, pag nag-intubate ka, yung maunahan mo, yung first pass, no? Naka-mention yata yun dito, medyo maliit kasi yun. Consider video laryngoscopy. Use intubator with highest likelihood of first pass success. O yun, nabasa ko. First pass success. Yan. So, usually, pag nagtawag ka ng code blue, mabilis ka agad mag-responde ang tao. Kailangan yung ating anesthetist or intensivist nandyan ka agad sa bungad para makomply natin tong 2 minutes. Pansinin nyo, ito, pagbagsak ng pasyente, perform ka CPR, tapos hook to defibrillator pa lang, hook to defibrillator, assuming AED override, run ka 2 minutes, fire ako. So 2 minutes, assuming nag-start up ka, wala pang AED, assuming may 2 minutes head start ka, may 4 minutes ako ngayon. By the time dito, nag-intubate na ako. Dito yung bago. So pag tumingin ka ng bagong algorithm, tingnan nyo lang to because this is the latest algorithm. Okay? Now, this is what it means for you to go into advanced life support. So 1, CPR quality mo, pulse hard, pulse fast with adequate recoil, minimize interruption, avoid excessive ventilation kasi in-expect nila na meron ka ng bag valve mask, tapos change compressor every 2 minutes, mga ganun, so on and so forth. Pababa ka dito sa boxes na to, ito yung energy requirement by phasic 200 joules, pag monophasic 360. Ang ideal ngayon, pag nag-ISO ka, is 200 joules. Kasi pag 360, medyo harmful sa heart yun. So, pero meron pa rin mga 360 na kumakalat, marami dito sa Pilipinas, particularly sa mga probinsya. So, okay lang din yung 360. Better than no defibrillator. So, ito yung nadagdag nila, itong advanced airway kaagad. And then yung drug therapy, initially tatlo, it's either epi. Epi is, pwedeng epi ka lang all throughout, walang problema. No? Pwedeng epi ka, tapos amyo. Tapos, or epi, amyo. or epi-lido or epi-lido, mga ganon. Tapos yung return of spontaneous circulation, ano ang kailangan gawin? Okay? Now, ito yung mas pinalalim natin. Pinalaki ko lang yung font kasi medyo under 2020 with 2022 interim guideline. Tingnan mo ang yellow. Itong yellow na to highlights, ito yung new paradigm na nilagay nila. Don't PPE ito. So naka-yellow yan. Okay? And accomplish it ASAP. Ngayon, down the line, naka-intubate na ako. Okay? So, epi ako, pwedeng epi or amyo. And then, hanapin yung reversible cause. Kung asystole naman ako, hanapin ko rin yung reversible causes. No? Tapos, kailangan nakahook ako sa capnometer. Yung reversible causes, ito. Yung 6H60s or 5H5Ps. Kasi hanggat hindi natin to i-reverse, hindi yan mabubuhay. So matutunan nyo to along the way sa lecture ko. Now, this is the interim guideline. Ginawa siya kasagsagan ng COVID. Kaya magulat kayo, strictly nasa level 4, level 3, level 4 yata. Kakaiba yung inyong sa amin. Nasanay kasi ako pag level A, yun ang pinaka-highest sa amin. Sa inyo kasi counting. Level 1, level 2, level 3, level 4. Sa military MOP, military operation, postural, yung nila, yung protection. Levels, level A, B, C, D kami. So, kailangan complete PPE as in level 4 yata tawag niya sa pinaka-fully Tapos, limit personnel with adequate wind corridor. Kung pwede, ang tamper mo, CPR tamper mo or yung mechanical CPR devices mo, meron ka. Plus, meron din, mas maganda kung meron ka ATV or automated transport ventilator. So, siya nagbibigay ng hangin. Hindi ka na nagbabag. Para siyang it's a mechanical, para siyang mech vent, except na maliit lang siya. Hanapin ko nga yan para mapakita ko tomorrow. I look for it. It's somewhere here. Now, ito naman, nabanggit ko na kanina, the using of HEPA filter, yung pinakamalaki nasa lahat ng rooms ninyo. Pangalawa, yung naka-attach sa bag valve mask. Tapos, intubate early with a cuff tube. Okay. Tapos, kailangan naka-mech vent siya. Kung ongoing ang CPR, okay lang yung mech vent. No? Pwede mo lang siyang hintuin. Automatic shut off lang muna. Pag pwede ka mag-fire kung takot ka kasi grabing hangin yan. Pero, kung naka-mech vent siya, actually, you can do CPR all throughout. Plus, you can fire the defibrillator. Okay? Engage the intubator with highest chance of first pass success, yung magaling na intensivist ninyo. Kung kailangan i-intubate, hinto. No? Ang pinakamatagal is hold mataas na ang 20 seconds, mataas na yan. Consider use of visual laryngoscopy. Tapos, before intubation, kailangan nakapag 30:2 ka using BVN. Sa adult naman, passive oxygenation with non-rebreather mask. Kung dalawang fail ka, depende sa inyong protocol, or wala talagang standard laryngoscope aided intubation, pwede ka supraglottic. Tapos wag maligalig yung airway ko, minimize ang closed circuit disconnection. Now, either leaving the patient on neck vent na merong HEPA filter. Tapos, to maintain a closed circuit and reduce aerosolization. No? And that's true. Yan ang emphasis natin. Tapos yung ventilator, makatulad kahapon, pumunta ako sa ICU. Adjust mo yung settings to allow asynchronous ventilation. So, bigay lang siya ng hangin. Hindi katulad synchronous. No? So, time chest compressions with ventilation in newborn. And meron tayo kukonsider na following. Yung FiO2 to 1.0. Tapos pwede tayong gumamit yung either pressure or volume of 46 ml kilo body weight. So, ano nga yung sa akin, ml yun, tingnan ko dito. Adjust the trigger to off to prevent hyperventilation ng air trapping. Doon ka sa medyo bare minimum. Yung ventilator nyo, medyo high-tech sa inyo kasi ako medyo hindi ko ito napapractice. Tapos ang aking rate is 10 breaths per minute. No? Pag-ado. PEEP mo. PEEP level to balance lung volumes and venous return. Okay, huwag kayo magpa-excess. Saglit. Adjust alarms to deliver full breaths and asynchronous chest compression. So, kanya-kanyang trabaho lang. So, bugal lang siya, no? Kasi pag advanced airway na, asynchronous na yun. No? Hindi katulad ng walang advanced airway. Ito, every 5 to 6 seconds. Tapos, ensure endotracheal tube, tracheostomy, tube or tracheostomy and ventilator circuit, security to prevent unplanned extubation. And kung bumalik sa ROSC, set ventilator settings as appropriate to patients clinical condition. So, pwede tayo magbaba